There's scientific data. It's telling us, yes, there's a reason to do 10 years versus 5 years.
And now we know.
Now you know. So, Dayush, tell me more. What would be your major question about healthcare or cancer, if you could think of a question?
Well, I think we should just remind the listeners that if they have any questions, they should call 1-800-321-0710. I guess my question...
What's that number again?
That's 1-800-321-0710.
Okay.
We got a doctor on the line, free consultations. That's the way I say it.
Well, it's not really free consultation because it's a chance to talk. It's not a consultation. Consultation means you examine the patient and get a history, but something to talk about and maybe to start a process that can do some good for a person.
Right, that's what I meant. But as far as any questions I'd have as a man approaching his 30s, I wonder about prostate cancer. What can you tell me about avoiding that or screening for it? What should I do to try to stay healthy?
Well, actually, there's several studies that have looked at that. We're going to talk about it one later on, but one thing is just to have good physical health. Studies have shown that men that have good physical health have a lower rate of mortality from a variety of cancers and actually even developing a variety of cancers. So men who are physically fit,
I should jog more,
active, have lower rates of cancer. As far as screening, the most important things are physical exam and blood test. The usual blood test is prostatic specific antigen, the PSA. And normally we don't start in people who are 30 unless there's a strong family history. Usually that started around 40 or 50. And actually there's a big controversy right now whether men should get screened at all.
Really? Why is that? I thought screening was always a good thing.
Well, for whatever reason, and it's a very long, complex argument, some people believe that too many men with prostate cancer are being diagnosed and treated, and we should try to reduce the number of men diagnosed and treated. Now, in my experience, most men who have prostate cancer want to know about it and want to be treated and don't want to have a recurrence of the cancer.
Sure.
Prostate cancer, when it comes back, is a pretty painful cancer because the cancer often spreads to the bones. Tens of thousands of men a year in America die of prostate cancer, so it is one of the big killers. But it is one of those controversial diseases, and I personally think most men want to know about the cancer and then make an informed decision about what's the best form of treatment.
Yeah, better safe than sorry, right?
We just had a caller, actually, Friday called in our office with a Gleason 7 cancer, prostate cancer. So he was about a 60-year-old man. Gleason score is a score made by the pathologic analysis. So when men have a biopsy, the pathologist looks at the cells under the microscope.
10, right?
And so there's a scale of 1 to 5 in two different areas. So 1 is the best you can have in one area, 5 is the worst you can have in one area.
Right.
And then the pathologist will actually add them up. So the best you can possibly have is 1 plus 1 equals 2, which almost never occurs. And the worst you can have is 5 plus 5 equals 10, which is the worst, and that does occur. And when you have the PSA is less than 10 when you have cancer are considered better. PSAs more than 10 are considered unfavorable. Again, the PSA is the blood test.
Right.
Gleason score is the appearance of the cancer under the microscope. So if you have a PSA that's more than 10 and a Gleason's that's higher than 6, so 7, 8, 9, or 10, those are considered more aggressive cancers.
Okay.
We're going to interrupt this discussion. Frank is on the line from Long Island, and he wants to know about glioblastomas.
Hello, Frank.
Hello.
How are you today?
Okay.
What can we help you with?
My sister-in-law has been diagnosed with glioblastoma.
I'm sorry to hear that.
Yeah, it is. I mean, from what I'm hearing right now from the different doctors, it seems to be
Frank, if you could turn off your radio, I think you'll get a clearer sound.
okay.
Otherwise, I get to hear myself about 16 times.
Okay.
All right, tell us about your sister, Frank.
No, my sister-in-law.
How old is she?
70.
And when was she diagnosed?
About a year ago.
And what were her symptoms then?
Really, I don't think she had any symptoms really that she complained about.
Okay, so she was found out with glioblastoma. Did she have surgery or biopsy?
She had a biopsy, and they said it was cancer, and then she had surgery.
And then she had chemo and radiation for the
No,
glioblastoma?
she couldn't get the chemo because there was some toxic involvement with the liver.
Okay, so she had the usual chemo is Temodar. That's usually given and has actually been shown to increase the survival of people with glioblastomas. Glioblastomas, for the listeners who don't know, is one of the more aggressive brain tumors. Affects the brain or the tissues of the brain, and is usually treated with some form of surgery, radiation, and chemo. So she was treated a year ago, and what happened?
Well, the only thing we noticed is the fact that her personality has changed. She become a little bit depressed.
Sorry about that.
That's
Was she on
odd.
medicines like Decadron or steroid medicines to reduce swelling in the brain?
Yeah.
Yeah, sometimes the steroids can cause people to be more moody. That's one reason. And what happened to the cancer?
Well, she passed away just recently. But
I'm sorry to hear that.
yeah, my question is, was there any? Is that just a fatal condition that there's very little that can be done?
Well, we actually treat and have the ability to retreat people with glioblastomas. Our longest person alive, cancer-free, is now out 22 years, cancer-free. Who I treated him when he was 37, and so he's now about 59 years old, cancer-free. So there are some people with glioblastomas who do well. There's treatment, and we use what's called fractionated brain radiosurgery. So we use a treatment to be able to retreat people safely, and we believe that we can extend the life of patients with recurrent glioblastomas. So yes, there are treatments out there that could help. Not every person gets the treatments for whatever reason. I'm sorry to hear about your sister-in-law. The Temodar medicine probably would have helped, at least statistically it would have helped with her, and possibly radiosurgery to focus the beams just on the brain tumor.
I see. Okay.
All right, I'm sorry about your sister-in-law, but hopefully the listeners will learn something about glioblastomas from what she experienced and can get great care.
Thank you very much.
All right, God bless you.
Condolences.
Bye-bye. We also now have on the line Jack from Long Island. Good morning.
Good morning, sir.
How are you today?
Well, still pretty sick from the treatment I've been receiving for pancreatic cancer. 2 years ago, I was diagnosed with a lung tumor cancer, third stage, and that was treated with chemo and radiation, and it put it in a dormant situation,
Good.
which it is today. But
All
then
right.
the fifth PET scan showed a spot on the pancreas, which 3 months ago, which I have been treated for with about 16 radiations and 3 chemos. And I had about 12 radiations and 3 chemos to go, but I got so sick I couldn't take them, and my oncologist, Dr. Regina Jablonski, stopped it altogether for over a week. She's going to start me again tomorrow on the radiation and the chemo, not right away, but the radiation first. And I'm wondering what chances I have to come out alive. I'm 85, but I'm ready to go to heaven. My wife's there waiting for me. But I wonder.
No rush. Don't
No,
rush.
no,
to get
yeah,
there.
I don't want to rush. Because when I'm normal, I do like to take walks and eat good food. But even that was gone when I was so sick with nausea and the sickness
Sure.
from the radiation.
You
It's going
said-
right. They hit me 3 times, one on each side and one in the center, because they can't go through the back because of the spinal column naturally.
Well, we do what's called stereotactic radiosurgery, so our treatment is different. We could do as few as 5 treatments to the pancreas. Our success rate means where we hit the pancreas cancer, and we've treated hundreds, probably 1,000 or more patients like you, is about 90%. We can stop the cancer where we aim the beam for pancreas. So our treatment is more focused than usual. It's more exact than usual. We give more dose than usual, and we do it more precisely so that you can get what we think are better results in fewer treatments. So it may be useful for someone like you. It's useful probably for anyone with cancer, but for you especially because you're having side effects from the usual treatment.
Yeah, seriously. How do I mention this to my oncologist, Dr. Jablonski?
Well, look, every doctor has to give you their best treatment, and it's up to you to decide. And I'm sure Dr. Jablonski is a great doctor.
She is. She's wonderful, doctor.
And so the whole idea is to try to get the best possible treatment for you. And sometimes you need a second opinion. And, we deal with people who want a second opinion, and people call in our number, 212-CHOICES, during the week, 212-CHOICES.
That's easy to remember.
It's easy to remember. You can call in. We'll send you a booklet. We have a free booklet and a DVD about it. We have a lot of examples of pancreas cancers in our booklets, also of lung cancers. So it's something for you to think about, that there are other choices out there, and those other choices might be less toxic for you than the usual treatment.
Oh, thank you, doctor. I'm going to mention this to Dr. Jablonski and see what she says. Maybe I will go to 212-CHOICES.
All right. God bless you, and thank you.
All right. God bless you, sir. Thank you also. Bye-bye.
This guy Jack sounds so healthy, doesn't he?
Well, that's something that we can actually talk about also, and there's so much to talk about. There's like too much to talk about. The lifespan in America is getting more and more. When my grandfather was born 100 years ago, lifespan for a male in America was about 50 years.
Wow, it's like 80-something now, no?
Right, so actually there's
79.
an article that just came out that looked at lifespan.
Uh-huh.
Actually looked at differences between black and white people in America.
Uh-huh.
And right now, whites live 4 years longer than blacks, but that gap is getting narrower and narrower.
Well, that's good, isn't it?
It's very good.
Yeah.
And everyone's living longer. The things that are taken away from mortality are heart disease and cancer, homicide, diabetes, and infant mortality. So why do blacks live less long than whites? It's those reasons: heart disease, cancer, homicide, diabetes, and mortality. And of course, this show is dedicated to try to reduce cancer deaths.
Absolutely.
But blacks have made great gains, and their life expectancy since 1970 is up by 17%.
Wow.
So actually, the gains in the black community are greater than the gains in the white community. The white community was up 11%.
Okay.
and
Everybody's
why
living
is that?
longer.
There's decreased rates of AIDS, decreased rates of homicide, which is improving longevity. Black people have had higher rates of heart disease, but they're also benefiting more from treatment. So that's one reason why the longevity is improving.
Yeah, healthcare keeps getting better.
Healthcare gets better.
And obviously, when you're not shot, you live longer.
Correct. So we want to avoid violence and avoid harmful things. So life expectancy right now in blacks is 75 years. And just in 1970, so when I graduated high school, more or less, it was only 64 years. And in the same period of time for whites, longevity went up from 72 years to 79 years. And in 1930, so in the time of our grandparents, even parents, life expectancy was 48 years for blacks and 60 for whites.
Oh, wow. And that's both genders, right? Is there a
Yes.
gender breakdown there?
Well, women live longer than men.
Right.
Infant mortality over the last years from 2005 to 2011 in the black community has fallen by